Welcome to this lecture on the principle of immunology. Today, we are going to explore the Gell and Coombs classification of hypersensitivity. Imagine your immune system as a highly trained security system designed to protect your house from dangerous burglars. Most of the time, it works perfectly. But what happens when it sounds a destructive alarm just because a harmless butterfly flew through the window? That is exactly what happens in a hypersensitivity reaction. Let us dive in and understand how scientists categorize these biological false alarms. Now that we have our security system analogy, let us look at what this means biologically. A hypersensitivity reaction occurs when your immune system overreacts to harmless substances, like pollen or peanuts. The Gell and Coombs classification is a foundational framework that allows doctors to categorize these false alarms. It is not just about knowing that an allergy exists, it is about understanding exactly which weapons the immune system used inappropriately. By pinpointing the exact cellular mechanism that malfunctioned, medical professionals can figure out how to stop the reaction and ultimately save the patient's life. Building on that foundation, let us examine the first category. Type 1 is known as immediate hypersensitivity. This is the mechanism behind classic allergies and severe reactions like anaphylaxis. It is primarily driven by IgE antibodies and mast cells. When a person is exposed to an allergen, these IgE antibodies bind to it and signal the mast cells to release inflammatory chemicals, such as histamine, almost instantly. This rapid response is why someone with a severe peanut allergy can experience life-threatening symptoms within minutes of exposure. Moving on from immediate allergies, we encounter type 2, which is known as cytotoxic hypersensitivity. In this scenario, the immune system makes a critical targeting error. Instead of attacking foreign invaders, IgG or IgM antibodies mistakenly bind to the body's own healthy cells. Once these antibodies attach, they mark the healthy cells for destruction by other immune components. This mechanism is often seen in autoimmune hemolytic anemia, or mismatched blood transfusions, where the body literally turns its own defense mechanisms against its own tissues, leading to cellular death. Next, we have type 3 hypersensitivity, which operates quite differently. This is an immune complex-mediated reaction. Here, antigens and antibodies bind together to form large clumps, known as immune complexes. Normally, the body clears these out, but in type 3, these clumps escape clearance and get physically stuck in various tissues, most commonly in the kidneys, joints, or blood vessels. Wherever they settle, they trigger a massive, localized inflammatory response. This is the underlying mechanism for diseases like lupus or rheumatoid arthritis, where chronic inflammation causes severe tissue damage over time. Finally, we reach type 4, which stands out from the other three. This is called delayed type hypersensitivity. It is unique because it is not driven by antibodies at all. Instead, it is mediated entirely by T cells. Because it relies on cellular interactions rather than circulating antibodies, this reaction takes several days to fully manifest. A classic example of this is the itchy rash you get from poison ivy, or the reaction to a cheap metal watch strap. The delay is a hallmark sign that T cells are orchestrating the immune response. Let us consolidate what we just learned by looking at this comprehensive diagram. On the top left, you see type 1, where an allergen binds to IgE on a mast cell, triggering histamine release. On the top right is type 2, showing IgG antibodies directly targeting a host cell for destruction. On the bottom left, Type 3 illustrates those immune complexes depositing into a blood vessel wall, causing inflammation. Finally, on the bottom right, type 4 shows an antigen-presenting cell activating a T cell, which then releases cytokines to activate macrophages. This visual summary perfectly captures the distinct cellular mechanisms of each type. Now that we have seen the mechanisms, we must ask, why does this classification matter in a hospital? Understanding these 4 types is absolutely critical for modern medicine because treatments depend entirely on the underlying mechanism. If a patient has a type 1 peanut allergy, the doctor must administer epinephrine immediately to halt mast cell degranulation. But if a patient has a type 4 reaction from a watch strap, epinephrine will do absolutely nothing. They need topical corticosteroids instead. Without the Gell and Coombs framework, doctors would be guessing, potentially giving ineffective or dangerous treatments. To truly understand how a type 1 reaction triggers, we must look at the mathematics of allergen binding. Before a mast cell releases histamine, a specific proportion of its receptors must be activated. We model this using the fractional receptor occupancy formula. In this equation, Y represents the fractional occupancy, ranging from 0 to 1. The symbol Ag in brackets is the allergen concentration in the patient's system. Finally, Kd is the dissociation constant, measuring how tightly the antibody binds the allergen. A lower Kd means a stronger bind. As allergen concentration increases, occupancy increases, leading to a stronger reaction. Let us apply this formula with a concrete example. Imagine a patient with a severe pollen allergy. We are given that the pollen allergen concentration in their nasal mucosa is 300 nanomoles per liter. Their specific IgE antibodies have a dissociation constant of 100 nanomoles per liter. We need to find the fractional occupancy to predict the allergy severity. We substitute 300 for the allergen concentration and 100 for the dissociation constant into our formula. Dividing 300 by 400 gives us 0.75. This means 75% of the receptors are bound, indicating a massive signal to degranulate. Now that we know the fraction of receptors bound, we can calculate the actual physical response of the cell. The mast cell releases histamine proportionally to how many receptors are activated. We express this using a simple linear scaling equation. Here, H represents the total amount of histamine released into the tissue, which causes the swelling and itching. H max is the absolute maximum histamine the cell has stored in its granules. Y is the fractional occupancy we just learned to calculate. As occupancy approaches 100%, histamine release approaches its maximum, which can cause life-threatening anaphylactic shock. Building on our previous example, let us determine if the patient will actually show visible symptoms. Suppose the patient's mast cells have a maximum histamine capacity of 120 micrograms per milliliter. Clinical data shows symptoms appear only if the local histamine exceeds a threshold of 50 micrograms per milliliter. We use our calculated fractional occupancy of 0.75. Multiplying the maximum capacity of 120 by 0.75 gives us exactly 90 micrograms per milliliter of released histamine. Because 90 is significantly greater than the symptom threshold of 50, we can definitively conclude the patient will suffer a severe allergic attack. We have covered a lot of ground today, so let us summarize the key takeaways. The Gell and Coombs classification elegantly organizes immune overreactions into 4 logical categories: type 1, immediate; type 2, cytotoxic; type 3, immune complex; and type 4 delayed. We saw how understanding these specific mechanisms is essential for doctors to prescribe the correct treatments, like epinephrine versus corticosteroids. Finally, we learned how mathematical kinetics, such as receptor occupancy and histamine release, allow us to predict the severity of these reactions. You now have a solid foundational understanding of clinical immunology. Great work!